afternoon, and thank you for the opportunity to present an aspect of my MEd. I am Dr. Leanthea Enoch, and co-presenting is Dr. Rena Abraham, who supervised my thesis. Our topic is assessing medical students' ability to bridge the theory-practice gap in clinical skills following online learning during the COVID-19 pandemic. COVID-19 catapulted clinical skills teaching onto an online platform, and we needed to adapt teaching to help our students bridge the potential gap in their training. While the transition to online learning was sudden, it was important to maintain the aims of the pre-COVID curriculum. Traditional teaching includes affective, cognitive, and psychomotor skills. These skills require varying degrees of transfer from the learning environment to the application environment. Online learning created further distance in transfer, especially with hands-on skills. To help bridge the gap, we emphasized knowledge retention, incorporating clinical reasoning during all our teaching sessions. Spaced learning allowed for repetition of topics days, weeks, and months after initially introducing a new skill. This promotes decision-making using System 2 of the dual process theory, since students rely on recall rather than experience when assessing and managing patients. While the Clinical Skills Laboratory provides a safe environment for students to learn skills for the first time, it doesn't completely satisfy the needs of the learner. The transition to online learning was unprecedented, but provided an opportunity to try new teaching strategies. We felt that live, interactive sessions over the Zoom platform would enhance learning. We wanted to investigate the effectiveness of our online intervention in teaching clinical skills. We conducted a cross-sectional prospective study at the Nelson Mandela School of Medicine at UKZN in 2021 to evaluate the adaptations to the curriculum. We did a comparative analysis of the impact of online, blended, and face-to-face learning on medical students' clinical competency in the affective, cognitive, and psychomotor domains. According to the revised Bloom's taxonomy, the affective domain teaches behavioral knowledge, the cognitive domain teaches comprehension of concepts, and the psychomotor domain enhances performance knowledge. Competence is achieved as each level is mastered. Our adapted teaching design and clinical skills retain the core principles of training while integrating key components of each domain. For the affective domain, we conducted live Zoom sessions in small groups with all students, tutors, and simulated patients being remote. Cameras were kept on and students played the role of the doctor, taking the history from the simulated patient, role played by the tutor. The facilitator and the remaining students gave feedback on the simulated doctor's performance. This domain adapted very well to the online platform. Examination skills require a hands-on approach. To adapt, we adopted a similar strategy of having cameras on, and where appropriate, students demonstrated skills on themselves. Other adaptations to the examination skills integrated physiology and anatomy into the assessment of the clinical sign. Connecting these aspects improves understanding and retention, a step often missing in the clinical skills laboratory, as signs require imagination in the absence of actual patients. This is an excerpt from a teaching session where students had to localize a cranial nerve lesion in a patient presenting with a dilated right pupil. Procedural skills also require hands-on learning and specialized equipment. We had to creatively adapt by including innovative simulations where students had to collect simple household items and make a model on which to attempt the skill. This integrated an understanding of the anatomy and gave a tactile experience of the skill. Here, students created a cervix and a speculum to understand the pap smear skill. Our post-meeting feedback reported that students found these exercises greatly beneficial. Cognitive knowledge was integrated at all levels of student engagement. During live sessions, students were presented with clinical scenarios, polls, and quizzes. The case prompted students to reason and make decisions based on new information. They responded in real time, allowing the tutor to detect gaps in their knowledge, thereby identifying at-risk students and offering immediate remediation. To determine if adequate transfer and retention of skills and knowledge had occurred, we conducted an objective, structured clinical examination in two parts. Part 1 assessed psychomotor skills in an on-site formative OSCE. All third-year students from 2021 were invited to participate. 101 student volunteers met the COVID-19 screening criteria and attended the session. This group was labelled blended learners and were demographically representative of the third-year class. All remaining students from the third-year class were labelled the e-learning group since all their learning had been exclusively online. After screening, the blended students had 15 minutes to familiarise themselves with new equipment and to practice the skill on their own. They then proceeded to a tutor who examined them in the obstetric and the pap smear skills. They had 5 minutes to complete each skill and were scored using the standard OSCE mark sheet. This was followed by feedback and correction from the tutor. They then proceeded to continue with self-directed learning and practice at other procedural stations. The OSCE assessed far transfer as the online learning platform differed vastly from the skills laboratory, where the students used specialized equipment and models for the first time. Part 2 was the online summative OSCE, which was conducted on Zoom to assess the affective and cognitive domains of clinical skills and involved all third-year students. Students were randomly assigned to an examiner in a breakout room. For the affective skill, the examiner role-played a simulated patient and scored the student on the process skills required for gathering the history and reaching a differential diagnosis. This was followed by 2 5-minute stations that assessed the cognitive domain in a Viva-Voce format. Students had to discuss examinations and procedures based on a clinical context. These 2 skills assessed near transfer as the assessment environment was nearly identical to the learning environment. Data was collected in the form of OSCE scores and scores achieved in all components were statistically analyzed. The blended learners achieved 90% in the psychomotor domain. The affective skills scores showed that the overall class performance was good. However, the blended learners performed better than the e-learning group. Similar results were seen in the cognitive domain. We had established that our students displayed competence for their level and wanted to know how they compared to traditional students who were taught face-to-face pre-pandemic. The 2019 face-to-face third-year class marks were used as a benchmark in the history taking and the pap smear skills. The 2021 students performed significantly better than the traditional on-site 2019 group in both exams. When all 3 groups were compared, the blended learners performed significantly better than the e-learning group as well as the face-to-face group. In conclusion, to enhance medical education, we must consider revising the online on-site distribution of synchronous teaching delivery. This includes collaboration by all role players, shifts within the organizational structure towards a blended approach, instructional design aimed at integrating competency in all domains of clinical skills, application opportunities with reflection and feedback from both peers and tutors, frequent evaluation of both students and the curriculum design to optimize all tutor-student encounters. This will equip our students with knowledge needed for decision-making, which is the hallmark of the competent physician. Following our study, we offer some take-home points. The blended learning approach is shown to be superior to online or on-site practices alone. The benefits of the online platform in terms of costs, time, flexibility potentially lead to better academic outcomes when combined with targeted on-site practice. The medical school, as well as tutors, play a vital role in overcoming learning challenges and achieving higher transfer levels of learning. A conceptual framework that promotes and formalizes this hybrid approach may help decentralize the classroom and be effective and economical as a learning environment that accommodates large and diverse student cohorts. This unprecedented opportunity allowed us to pilot innovative strategies that saw medical students demonstrate various degrees of near and far transfer to bridge the theory-practice gap in the 3 domains of clinical skills. And by active collaboration at the modular planning phase, we can formalize the gains made and have a curriculum that not only survived the pandemic, but evolves medical education. Thank you so much for your time, and I look forward to answering your questions.